All right, well, good morning, everybody. I'm going to go over today some bacterial infections, histology of bacterial infections. And when you think about bacterial infections, there's really quite a few of them out there that can affect the skin. So think about whether they're pyogenic bacteria, whether they're like gram-positive cocci like staph or strep, what kind of infections those can cause. Think about whether they're gram-negative infections, things like Pseudomonas that can cause ecthyma and cause ecthyma gangrenosum vasculitis, especially if somebody's immunocompromised in some cases. Whether they're gram-negative cocci like gonococcemia or gonorrhea, that involve the skin and get pustules there and septic vasculitis. And then gram-positive rods like Clostridium, things of that nature can give you things like horrible dissecting cellulitis-like eruptions and necrotizing fasciitis-like eruptions and things like that, gas gangrene. And then the small gram-positive organisms like Vibrio, Vibrio parahemolyticus. So those are kind of the, pyogenic / organisms that we tend to think of causing those kind of infections. And then bacteria like AFB, those are bacteria, obviously. And then how the different AFB infections can involve the skin, atypical mycobacteria, Hansen's disease, those organisms. And then the secondary infections, the tuberculids, that can develop in association with Mycobacterium tuberculosis, things like erythema induratum, nodular vasculitis, so-called papillonecrotic tuberculid that sort of looks like granulomatous rosacea. Like a lot of those probably were granulomatous rosacea, but they can occur in the skin. And then spirochetal infections. Those are considered to be bacteria also. We have a whole host of those. So we're not going to go over every single one of them today. Obviously, there's too many to go over in a 30-minute, 45-minute talk, but we are going to go over some of the main ones, and then you need to supplement this with your own study and know all the different ways that these different infections can cause manifestations in the skin and what kind of dermatopathology gets produced from it. So the first one we're going to take a look at is Bullous impetigo. And Bullous impetigo, caused by gram-positive cocci, usually staph, sometimes strep, but the vast majority of these are staph now, and they can be either just MSSA, methicillin sensitive, or methicillin resistant staph. And the classic pattern is a very superficial subcorneal blister, like you see here, with neutrophils in the blister space, as you see here, and sometimes some acantholytic cells, as you see over here. So the differential diagnosis of that pattern obviously is going to be superficial pemphigus, right? That can give you a subcorneal blister with acantholysis. And it makes a lot of sense that it would, because the way that you get the blister in this condition, Bullous impetigo, or in staph scalded skin syndrome, is that the bacterium produces an epidermolytic toxin that causes lysis of the desmosomes, very similar to the way the antibodies in superficial pemphigus lead to lysis of the desmogliin around the keratinocytes. So it would make sense that they would look the same. Most of the time, in my experience, the number of acantholytic cells in Bullous impetigo is fewer than you see with superficial pemphigus. And usually you don't get a lot of extension down follicular epithelium in Bullous impetigo as opposed to pemphigus, but that's not 100%. So obviously the best way to tell would be to do immunofluorescence, which obviously would give you the intercellular IgG and C3 with superficial pemphigus, and would be negative in this condition. Now, the other thing that you look for, you can get either quite a few neutrophils here. So you can imagine if you had all these neutrophils that you would get that honey-colored crust that we talk about. And these blisters tend to be so flaccid that they usually rupture pretty quickly. It's kind of somewhat unusual to see an intact blister in a patient that's got bullous impetigo, just because they're so superficial, and it doesn't take much trauma for them to rupture. So usually you just get that honey-colored crust morphology, which is really a kind of a scale crust. It's combined stratum corneum plus neutrophils, and that's why it's kind of honey-colored and yellow, as opposed to being dark blackish or reddish, which you see with a hemorrhagic crust. And there are some extravascular erythrocytes in this specimen. But if it's a hemorrhagic crust, it's going to look kind of black or dark, where if it's a honey-colored crust, it's going to have neutrophils in there. And if you do a gram stain, you may or may not see any organisms here. So again, you can have a relatively few number of bacteria release quite a bit of epidermolytic toxin that actually can cause the blister, but you can't actually see the organisms in the blister space all the time with the gram stain. You see it, it's great, and it helps you make the diagnosis. If you don't see it, it doesn't mean that it can't be bullous impetigo. But the most important thing is just to know that the pattern here, the superficial acantholytic changes here with the neutrophils and the subcorneal pustule. Now, obviously, when we think of subcorneal neutrophils, we think of not only these conditions, we also think about pustular psoriasis, think about fungal infections, candidiasis, dermatophyte infections can give you this pattern. So again, remember neutrophils, the cornified layer, and subcorneal blisters. Think about infectious diseases, think about bacteria, think about fungus, and then also think about psoriasis. And then obviously we mentioned pemphigus. Okay, so that's bullous impetigo. Now the next one we're going to take a look at is if that same bacteria get down into the dermis and form more of kind of a diffuse pattern, then we get cellulitis and erysipelas. And notice the pattern is completely different here. There's no involvement in the epidermis. So this is involving it's a bacterial infection of the dermis. And you get edema, sometimes you get prominent papillodermal edema. You can actually get secondary vesiculation here from the papillodermal edema resulting in a blister. It's not in the epidermis, it's in the dermis, actually. It's beneath the epidermis. And then you get what's called phlegmonous inflammation in the dermis, where you get kind of a diffuse interstitial, mostly infiltrate of neutrophils over a relatively broad front. And that's distinct from some of the other neutrophilic dermatoses, where you get more of a nodular infiltrate of neutrophils, like in Sweet's disease, for example, where you get a dense nodular infiltrate of neutrophils with papillodermal edema. This papillodermal edema is really secondary to the fact that the entire dermis is edematous, not just the papillary dermis, but also the reticular dermis. And it's got this more diffuse infiltrate of neutrophils. So interstitial infiltrate with neutrophils, if it's kind of sprinkling of neutrophils, it's probably something more like neutrophilic urticaria or some of the neutrophilic inflammatory dermatoses patterns, things like familial Mediterranean fever and those, and the type of neutrophilic infiltrate you can see in lupus. If it gets more nodular and diffuse, then you think of Sweets. If it gives you this kind of relatively diffuse infiltrate, but denser than the inflammatory dermatoses, you should think about cellulitis or erysipelas. And you may get a few other cells besides neutrophils here. You can get some histiocytes. Anytime you get a neutrophilic infiltrate, an abscess or whatever, early, it can be mostly neutrophils. Later, you can get some histiocytes that come in secondarily to try to clean everything up. So you may get some histiocytes here. You may get some eosinophils as well, but it's not in a eosinophilic allergic reaction. It's really due to this, to a bacterial infection. So if you see this pattern, think about erysipelas, think about cellulitis. Now, can we tell which bacterium causes this? The answer is no. The most common is going to be strep and staph and those, but if you get Haemophilus influenza, cellulitis, orbital cellulitis in a child, and you biopsy, it can look like this also. So anytime you get that dermis infected with bacteria in a more diffuse pattern, kind of dissecting, if you will, between the collagen bundles diffusely with a secondary inflammatory neutrophilic infiltrate that comes in, it can give you the same pattern. Okay, so less common to see that with Pseudomonas. I'd say the majority of the case, though, it's usually a gram-positive cocci that gives you this pattern. Okay, Here, we've got a different pattern. We've got a superficial and deep infiltrate of dark staining cells. So we know that a lot of these are going to be lymphocytes. And we immediately go to our differential diagnosis of the lymphocytic infiltrates. And the textbooks talk about the 5 L's, but you can really expand that a little bit more broadly. There's a few other things that can cause this pattern here. We also include Lyme disease, especially if there is a lymphoplasmacytic infiltrate. So if you see some plasma cells in addition to lymphocytes in this pattern, think about adding Lyme to the differential diagnosis, which is erythema chronica migrans, which is in the lymphocytic infiltrate sort of differential diagnosis of erythema annulare centrifugum, that sort of thing, which is also one of the lymphocytic infiltrates, or lymphocytic infiltrated Yesner, which is kind of where that came from. But here, if you actually look at this, unfortunately, a little bit of a fuzziness to this high magnification, but a number of these cells actually were plasma cells in addition to lymphocytes. And notice that there's an absence of mucin. So if you get this pattern that you see with mucin, you think about the tumor form of lupus erythematosus. If you see a prominent amount of papillodermal edema with no mucin, you think about polymorphous light eruption. You can actually see this pattern even in Hansen's disease sometimes with a relatively few number of histiocytes. If you get early indeterminate Hansen's disease, usually by the time you get tubercular Hansen's disease, you get some granulomatous inflammation. But you get relatively early Hansen's or like indeterminate Hansen's, that could actually look like a lymphocytic infiltrate also. So we put leprosy in the L's as well. But this is an example today of a bacterial infection. So it's got a superficial deep infiltrate with lymphocytes and some plasma cells. Obviously, you think about Lyme disease. And that's erythema chronica migrans caused by Borrelia. So Borrelia is a spirochete. It's an infection, bacterial infection. And you may actually be able to identify the organisms. If you do an immunoperoxidase stain directed to the actual Borrelia organism, it will highlight that. Sometimes if you do a stain, a immunoperoxidase stain T. pallidum, it will cross-react to the Borrelia. Not strongly, but you can sometimes see some reaction. You may pick up a few organisms. The classic stain is the Bosma-Steiner stain, which will highlight the organisms, but it's hard to see organisms with a silver stain. Those really have been replaced today by the use of immunoperoxidase stains. But anyway, this is yet another example of a bacterial infection inducing a different pattern, here inducing a lymphocytic infiltrate pattern with plasma cells. So if you see lymphocytic infiltrate with no plasma cells, think more of erythema annulare centrifugum and one of the gyrate erythemas. If you see some plasma cells in there, think about the possibility of this. And then, of course, you might even throw in there the theoretical possibility, especially if it's more nodular infiltrate of, say, a marginal zone lymphoma, which has lymphocytes and also plasma cells in the infiltrate. So that's EAC. Lyme ECM. Now, one other thing when we're looking at Lyme in this pattern here, if you the patient comes from an area where Lyme disease itself is not highly endemic, you should think about the so-called Stari syndrome, S-T-A-R-I, and that is also thought to be caused by a Borrelia that we just really haven't determined the exact nature of the pathogen. The patients usually get a history of a tick bite. They're often seen in the southeastern part of the United States. We see it in Texas frequently. People go camping, they get a tick bite, they get what looks like erythema chronica migrans. You look for Borrelia, you can't find it. Do serology, can't get it there either. And then you end up making the diagnosis of the Stari syndrome. And I think they're kind of narrowing down, finding the actual cause of this, but it's probably Lyme disease caused by a different Borrelia in a different part of the country, but it's basically looks the same. Okay, another spirochetal infection, and here we've got a different pattern. We've got a superficial and deep, somewhat psoriasiform band-like infiltrate, and even at low magnification, you say, wow, those cells are definitely not lymphocytes here. A lot of these, in this case, are histiocytes and also plasma cells. So, and notice that the histiocytes are forming granulomas, but they're not forming tight epithelioid granulomas like we see with sarcoidosis. It's not a palisaded granulomatous inflammatory infiltrate, so that's not really like a GA. And up here, you've got the psoriasiform lichenoid pattern. Even if you just had a superficial biopsy and you have this psoriasiform pattern with histiocytes and plasma cells, you should instantly think about the diagnosis of syphilis. Now, your board examination is going to have some questions about syphilis. They have probably questions about the therapy of syphilis. They had that on my exam. They're going to have it on your exam. They have it on every exam every year. They're going to have some questions on the dermatopathology of syphilis. They're going to have some questions on the different stages of syphilis. They're going to have questions about the epidemiology of syphilis. It's actually increasing in incidence today. So we're kind of in a mini epidemic of syphilis. So you really need to know about it, and you really need to think about it, and you need to know the histology of it as well. And this is the classic pattern, a superficial and deep psoriasiform lichenoid pattern with lymphocytes, histiocytes, poorly formed granulomas, and plasma cells. Now, I will tell you there's a truism about syphilis being the great imitator, and indeed I've seen probably 15 to 20 different patterns of syphilis histologically over the course of my career. I've seen some that have simulated lichen planus almost identically. I've seen some look exactly like pityriasis lichenoides. I've seen some look like psoriasis. The one thing that does tend to be the case is that you usually do see some eosinophils in there. I've obviously seen it look like PR. You see some plasma cells that are not eosinophils, but you can't see eosinophils. You can see any kind of cell in syphilis actually, but you usually do see at least a few plasma cells. So if you see plasma cells in a setting of a dermatitis, it's kind of widespread, you should think about the possibility of syphilis, and you should do special stains for spirochetes. And the best stain to do is now obviously an immunoperoxidase stain for Treponema pallidum. I happen to have one right here of this case, and it was loaded in this case with abundant spirochetes. Now there's several places to look. The best place to look is in the epidermis. That's the most common location for spirochetes. Here you see some right over here. There's a bunch, okay? But sometimes they actually are present in the granulomatous infiltrate in the dermis. So you have to look in here also. I've seen some where you don't have any in the epidermis and you see it in the infiltrate in the dermis. I've seen some cases where the spirochetes are present in the lower part of the inflammatory infiltrate. So we're down in this area. I don't see too many in this area, but sometimes that's where you see them. And then sometimes you see them in adnexal structures. I've seen them in nerves. I've seen them in sweat glands. So you kind of have to scroll around and look for the presence of the spirochetes. The most common location is the epidermis, but they can occur in other locations as well. So don't see any in the sweat glands here, but sometimes you do. So you have to look around and try to find the spirochetes. Most of the time, if they're positive, they're easy to see and you don't have to really look that hard. Now, I will also tell you that I've seen plenty of cases where there are 0 spirochetes in the skin and the patient's got a rip-roaring positive RPR. So just because you don't have a lot of spirochetes doesn't mean the patient doesn't have syphilis. So you want to make sure if the histology looks consistent with syphilis, just like we see histology looks consistent with infectious disease and the stains are negative, the same thing applies here. You can have a negative special stain, but the patient can still have syphilis. So you want to make sure that you get an RPR or VDRL in addition to that. Okay, here we've got a shave biopsy. And sadly enough, we don't like to get shave biopsies of inflammatory skin diseases, but we do sometimes because the clinician, especially when they're dealing with an infectious disease, they're not thinking about the possibility of an infection because maybe they see pseudoepitheliomatous hyperplasia. They say, well, this is a cancer. They do a shave, and then it turns out to be an infection. So you need to always be thinking that yourself when you're in your clinical practice. If something looks like a cancer and you do a shave biopsy and it shows a granulomatous infiltrate in there, say, wait a minute, maybe it's not cancer, maybe it's an infection with pseudoepitheliomatous hyperplasia, or maybe it's pseudoepitheliomatous hyperplasia sitting overlying a granular cell tumor or something like that. So just keep that in mind when you get a shave biopsy that you think is cancer and it's not cancer. And the most common pattern, as you all know from the lectures we've given over the last year, is that the most common pattern of a deep mycotic infection or of an AFB infection or something like that is a suppurative granulomatous inflammatory response with or without overlying pseudoepitheliomatous hyperplasia. In my experience, more pseudoepitheliomas, hyperplasia, overlying mycotic infections, less in AFB, but certainly you can get it in both. And so here you can see the granulomatous inflammatory infiltrate here. These are all histiocytes. May see some multinucleated histiocytes. And once again, fewer multinucleated histiocytes in AFB than in non-AFB infections, but you can see some in each. So here we would do special stains. And I believe the next slide is a phyte stain, which actually in this case, we maybe will be lucky and actually see some of the organisms here. Yeah, in this case, it's kind of hard to appreciate, but all this kind of pinkish material here, this reddish material, these are positive organisms of AFB. And it's just, I can't get much higher than this on the scan slide, unfortunately, but this thing was loaded with organisms. Now, this is sort of the exception rather than the rule. Most of the time, you get a suppurative granulomatous reaction and you'll say this really looks like an infection, and then you do a special stain and it's negative. Or you might find one or two organisms. That's all you need. If you find one or two organisms in something like, say, one of these atypical mycobacterial infections that gets induced by patients that go to a nail salon, and it's maybe Mycobacterium abscessus or something like that, you may only get one or two organisms in that situation. In mulcerans, you may see very few number of organisms, but they can still get a brisk inflammatory reaction. The general rule of thumb is the more granulomatous inflammation, the greater the inflammation, the lesser the organisms, which makes sense because the host is coming in and getting rid of them. But in some cases like here, I mean, this might have been an AIDS patient, might have been an MAI. An MAI would very commonly give you an abundance of organisms, even though the patient was immunocompromised, and they might even have a relatively brisk inflammatory infiltrate. They still have a lot of organisms when it's Mycobacterium avium intracellulare complex. Now, there are obviously the different types of microorganisms, the AFBs. I strongly recommend you learn the Runyon's group there, the rapid growers, the slow growers, the Mycobacterium kansasii and all of those. So you need to review that, make sure you bone up on that before the exam. And then, they need to know the difference between Hansen's disease and the AFB infections. They do look different. And the next one I do have is Hansen's. And again, there's basically, knowing Hansen's is really a very interesting thing. If you really know Hansen's disease, you know a whole lot about cutaneous immunology and immunopathology. And Hansen's is really a very logical disease when you think about it. It's almost too logical. It sort of fits everything beautifully when you think about it. You go from few organisms with lots of inflammation with tuberculoid granulomas and basically tuberculoid Hansen's disease. You actually get sarcoidal granulomatous inflammation in tuberculoid Hansen's disease. So you get a really brisk inflammatory reaction with epithelioid histiocytes with very few organisms. Many of you don't find any organisms. And then you go from the tuberculoid pole to the lepromatous pole. You kind of go through the borderline stage where you get features that look a little bit like lepromatous, a little bit like tuberculoid, fewer sarcoidal granulomas, more cells that may have some foamy histiocytes in there that may have some organisms. So when you go from borderline tuberculoid, few organisms, borderline lepromatous, you get more and more organisms. And then finally, when you get to polar lepromatous, you get very, very few sarcoidal granulomatous inflammatory infiltrates, and you get this more diffuse foamy histiocytic reaction that can be very diffuse. In fact, can involve virtually the entire dermis, going from, basically the grin zone beneath the epidermis all the way down to the subcutaneous fat. So here we're looking at a lesion that would be more on the polar or borderline lepromatous pole. We've got a diffuse infiltrate of these histiocytes. Notice the grin zone, so the epidermis is not involved very commonly in this. And you've got all of these very foamy histiocytes that contain these organisms in here. These are the globi of Virchow cells, and this is just loaded with AFB, with Mycobacterium leprae. So this is going to be either borderline or polar lepromatous, really multibacillary disease. So tuberculoid, paucibacillary, borderline lepromatous, and lepromatous is multibacillary disease. And then you talk about patients with the reactional disease. So you can get erythema nodosum leprosum, which is a leukocytoclastic vasculitis that's associated with Hansen's disease. And usually patients have a lot of organisms when they get that. And then you can get other reversal reactions and downgrading reactions, things of that nature that are associated with different stages in the inflammatory reaction. So again, I'm not going to go over all those today, but I would recommend that you learn those and know about those. And then obviously, if we were to do a phyte stain of something like this, it's going to be just absolutely loaded with organisms. And we happen to have a phyte stain in the next slide here. I think it's this one. No, I guess maybe you don't have a, yeah, we don't, I thought we had a phyte stain, but we don't. So anyway, this is polar lepromatous, Hansen's disease. And this one too. A higher magnification, this one here. Yeah, this one's different. Okay, so we don't have a phyte stain of that. But anyway, that would have been loaded with organisms. We wouldn't have any trouble finding it at all in that polar lepromatous Hansen's. Now the next case, different. We've got a suppurative granulomatous inflammatory reaction again. And notice we've also, this time we have a grain in tissue. Grain, okay? So anytime you got a grain, throws you to really just about three main items in the differential diagnosis. So you get a grain from pyogenic bacteria that form a colony in the skin, usually in an immunocompromised patient. You get a grain in somebody that has actinomycosis. Usually that's seen around the jaw area. Somebody's got, say, like a dental sinus or something, and actinomyces kind of grow in the oral cavity, and they end up forming colonies and giving you this pattern. And then nocardia, Nocardia asteroides, Nocardia brasiliensis, that can be associated with pulmonary alveolar proteinosis. That can give you grain. So those three main organisms can give you these grains in skin. Now you can also get mycotomas. Those are sort of, they're forming grains too. So I guess I would throw that in there as well. So that'd be kind of four things. And then special stains can help you here. Obviously, do a gram stain. If it's actinomyces, you're going to see some gram-positive filamentous rods forming this kind of grain-like organism here. And the grain is comprised of organisms, degenerated inflammatory cells, and then a proteinaceous debris that gives you this material. So it's not all organisms, but there are organisms in here. And if you do the special stain, you'll see the organisms in this proteinaceous granular material here as well. So that can help you. If you do a stain for AFB, nocardia is weakly acid-fast positive, so that's helpful in that situation. And obviously a GMS stain or a PAS stain is going to highlight fungi if it's a true eumycotic organism. But at the end of the day, probably the best thing to do would be to do a culture. I don't know that the board examination would show you a grain just like this and say, okay, which organism is this? If they showed you an obvious GMS stain and was positive, you see hyphae in there, you could call it a mycotic grain. If you've had an AFB that was strongly positive, you know, call it nocardia. This was a patient that we thought actually had nocardia in this case, and it was very weakly AFB positive. But and nocardia is thought to be a sort of primitive bacterium, so it would fall into this bacterial theme we're talking about today. But basically, make sure you know your grains, make sure you realize the differential diagnosis of the grains and granules of tissue that can cause this pattern. Notice it generally tends to get a suppurative granulomatous inflammatory reaction. Here's another superficial shave biopsy, and in this case, I think the main situation was we had another grain, and notice here, it looks a little different than that last grain. And this one's actually probably being transepidermally eliminated. This was a patient that we thought, we did a gram stain on this, and there was some gram positivity of these little areas in here. They're gram positive cocci. So in this case, we thought this was more likely botryomycosis, another example of where you have a pyogenic bacterium causing a grain in tissue. And this was, I believe, actually grew out staph in this case. So just another example to show you another grain in tissue. Last one we think was probably nocardia. This one is caused more by staphylococcus. And it looks a little bit different, but again, I don't think the board is going to ask you to really distinguish these just purely on morphology, but you should know the differential diagnosis of when you get a grain in tissue, what causes it, and they're likely to ask you some questions about the potential causes of that. If we're going to show you and expect you to distinguish them, they almost certainly would want you to recognize that with a special stain. Okay. Let's shave biopsy, and in this case, we're looking for, got almost no inflammation here. We don't know how deep the inflammation would go if we actually had a punch biopsy, but it shows a very sparse infiltrate. And I think this was really sent in to rule out tinea, rule out intertrigo. And so when you have that pattern, and notice that the cornified layer is kind of thick, you should also add in the differential diagnosis erythrasma. And erythrasma is caused by Corynebacteria. I believe they may have changed the terminology of Corynebacteria over the last couple of years. It's now got a sexual stage to it, so I think they got a new name for it. I don't think that you necessarily need to know that new name, but the traditional name is Corynebacterium. And basically, Corynebacterium, when it infects the groin area, causes erythrasma. And it's sometimes hard to see. I'm not sure I'm able to show you really good examples of that, but basically what you have are small, tiny filamentous gram-positive rods that grow in the stratum corneum in this area right here. And it kind of gives you a granular, discolored, bluish appearance to it. And it's really hard to appreciate on the scan slide. Let me look at the other piece of tissue. Maybe it'll show up a little better on that one. But this was an example of erythrasma in this case. So if they had erythrasma, they're going to give you one that you're going to have any trouble seeing the filamentous organisms. You can barely make it out right here on the scan slide, but that's what it looks like. Shows almost no inflammation. The differential diagnosis histologically is intertrigo, lichen simplex chronicus. You think of candidiasis, but look carefully for these filamentous organisms that stain kind of a bluish gray on hematoxylin and eosin. And if you did a gram stain or brown stain, then they would highlight a more purplish color because they are gram positive. Okay, and if you do a Woods lamp on this, it gives you that coral red fluorescence, which is due to the porphyrins that this bacteria releases when it is digesting the stratum corneum up here. So that's basically erythrasma. And you know your differential diagnosis of the other Corynebacterial infections. Corynebacterium can cause concretions on the hair shaft, not white piedra, but it can give you the trichomycosis axillaris. They can also give you the juvenile plantar dermatosis, pitted keratolysis. So know the several diseases that Corynebacterium can ultimately cause. Obviously, it's associated with acne as well. Okay, let's look at this last case. And low magnification, you can see you have a superficial perivascular infiltrate with all this papillodermal edema. And as you go to higher magnification, there are actually all these neutrophils here, and the neutrophils seem to be almost attacking these capillaries and blood vessels. And just little, some sludging of erythrocytes in here. There may actually be some possible actual thrombosis of some of these blood vessels. And if you look carefully, there actually is inflammation in the wall of these capillaries as well as being around them. And these are lymphocytes, but also there's a few neutrophils. But it's not really the classic pattern of leukocytoclastic vasculitis. It's really more of a lymphocytic infiltrate. And the lymphocytes are targeting the endothelial cells here. And all this inflammation up here in this papillodermal edema is secondary. And this is an example. I believe this was a person that may have had Rickettsial pox, or was thought even possibly to maybe have Rocky Mountain spotted fever. And Rickettsial are also in the primitive bacteria family, if you will. And the Rickettsial attack the endothelial cells. The endothelial cell is the cell that is targeted by the Rickettsial. And then the lymphocytes come in and say, hey, we got to get rid of these things. And they come in here and start attacking the rickettsia that have attacked the endothelial cells. And you get a lymphocytic vascular inflammatory reaction. And it looks like this. Lymphocytes are really around and inside the endothelial cells of the blood vessels. And it's one of the few conditions where you really and truly do get a lymphocytic vasculitis. You can get neutrophils in the infiltrate also, they come in secondarily, but the main cell that goes after these rickettsia is a lymphocyte. And you can actually get this pattern here that you see, this sort of lymphocytic vasculitis with papillodermal edema in some cases. And that's characteristic of these rickettsial dermatoses. Now, there are some differences between some. If they get injected at the site where the actual tick, say, bites the skin, you can get what looks like a bug bite. And then you get a secondary rickettsial inflammatory reaction of the blood vessels. If it's Rocky Mountain spotted fever, it would tend to look a little bit more like this. Rickettsial pox, that's actually also a vector-induced process that actually kind of occurs at the site where I believe it's a flea or I think it's a flea that actually causes rickettsial pox. It injects the rickettsia into the skin and it gets a secondary inflammatory reaction. So that's going to give you maybe more of this papillodermal edema component. If you see Rocky Mountain spotted fever, because you get such a dense inflammatory reaction of the blood vessels and you get secondary ischemic necrosis, that's kind of like an infarct. It's sort of analogous to septic vasculitis. That could give you something like this also, with necrosis of eccrine sweat units and ultimately necrosis of the epidermis. So that's very characteristic of these rickettsiosis when they involve the skin. Now, just kind of end up here, there are also situations where you get bacterial infections that cause secondary changes. We didn't talk a lot today about septic vasculitis, thymic gangrenosis, some of those things, but if you get like bacterial endocarditis, and then you get septic vasculitis where you get thrombosis of blood vessels with inflammatory infiltrates around those blood vessels in the skin. That's actually also caused by bacterial infections, not caused by primary infection in the skin, but it's caused by a secondary effect of a bacterial infection. Meningococcemia, gonococcemia, same thing. Person gets a systemic infection with these bacteria, and then you're getting secondary contagions involved in the skin. So that's another way that you can get cutaneous manifestations of bacterial infections other than the actual infection involving the skin itself. So just remember that as well. That's in the same family of these bacterial infections that infect the skin secondarily. So again, thanks for your attention. Hopefully this was educational for you. Next week, we're going to kind of conclude we may have one lecture after this, but next week we're going to talk about viral and other infections that may include basically finish up our survey of the infectious conditions that infect the skin. So good luck. These are important. The board loves to ask these questions because they have pathognomonic findings. So this is something you really need to spend some time with. Make sure you're well aware of these bacterial infections, and you'll get those questions right when they show the morphology to you on the examination. Take care. We'll see you next.